I'm going to talk about amyloid microangiopathy and the increasing deposition of amyloid with increasing age leads to cognitive impairment. So amyloid microangiopathy can be regarded as a form of vascular dementia. There can be microbleeds and patients have an increased risk of hemorrhage. So if you have hemorrhage in an atypical location in a normotensive patient, you can think of amyloid microangiopathy. We cannot see the small vessels on MR. We can only see the consequences. For example, microbleeds that are better visible on susceptibility weighted images than on gradient images. And in amyloid microangiopathy, these microbleeds are located mainly cortical and subcortical, so in the periphery of the brain. There can also be superficial siderosis and subarachnoid hemorrhage located over the convexity, and as said, sometimes patients present with lobar hemorrhage. The amyloid that is deposited in the media and adventitia of the small and medium-sized vessels of the brain is the same amyloid as in Alzheimer's disease, so there is an association between Alzheimer's disease and cerebral amyloid angiopathy. The deposition of amyloid leads to a decrease in elasticity and fragile vessels which are prone for hemorrhage, and therefore the ischemic white matter lesions cannot be treated with anticoagulative therapy because of the increased risk of hemorrhage. It's a very small balance. To make the diagnosis, you can combine clinical and imaging data, and sometimes there's also pathological data. So if you have a full brain post-mortem exam, you can make a definite diagnosis of cerebral amyloid angiopathy, but in most cases you can only diagnose probable or possible CAA, and you take into account the clinical findings, including amyloid spells and intracerebral hemorrhage, and imaging findings such as the microbleeds, the subarachnoid hemorrhage, and in the most recent classification also the white matter lesions, especially in the periphery of the brain, are taken into account. We do not have MR in all patients, and to make an estimation when you have a patient presenting with a lobar hemorrhage at an older age, whether it is cerebral amyloid angiopathy or another underlying cause, you can use the Edinburgh criteria, and then you also take into laboratory findings into account, such as ApoE4. And you can make a probable or high risk of possibility for cerebral amyloid angiopathy. The pathology starts way before the first symptoms, so the hemorrhage. 30 years before the first hemorrhage, there's deposition of amyloid in the vessel wall, leading to the loss of vasoreactivity because of the loss of elasticity, as mentioned before. And then there's 10 to 15 years before the hemorrhage, there's cognitive impairment because of the white matter lesions. And I want to make a few comments on why it is logical that the leptomeninges and the cortical vessels are both involved in amyloid angiopathy, and that is because they are the same vascular network. This was the intravascular cast in an adult brain that I had on the first slide, with the gray matter and the white matter. And you can see these vessels coming in from the leptomeninges. And if you've seen the vlogs about polymicrogyria with the glial limiting membrane and oligogyria of the cortical vessels entering the brain, you might remember that there is a glial limiting membrane with Cajal-Retsch cells surrounding the brain, and this prevents neurons to overmigrate. This is a 43-day-old human embryo from a tubal pregnancy that was terminated, and you can see the capillary plexus in the leptomeninges with nucleated red blood cells because it is such an early embryo. So you have this, in this drawing, schematic drawing, you have the glial limiting membrane and the brain, and then you have blood vessels, and this glial limiting membrane is impermeable. So there's a basal lamina. And there are mesodermal blood vessels also surrounded by a basal lamina. And what happens is when the vessels penetrate the brain, there's this interaction between those two impermeable basal laminas, which enables the vessels to enter the brain. So the cortical vessels are one vascular network, the same origin as the leptomeningeal vessels, and they are both involved in amyloid microangiopathy. There are also other types of microangiopathy that we will discuss later, and the deposition of amyloid in the vessel walls does not only lead to fragile vessels and microangiopathy, but also induces inflammation, and there is a subform of microangiopathy, amyloid microangiopathy, that is inflammatory, and we're going to talk about that next time.